I am Joel Kennedy, and I am partnered with Shannon Bork here. We are the leads for the Department of Family and Community Medicine at Lakeridge Health. And we're happy to bring, I want to say it's our 5th installment of education for the region. And we're happy today to introduce our mental health partners from both Ontario Shores and Lakeridge Health. There are 3 presentations today. We'll introduce the first group, and then Shannon will introduce the second group when we get there. I believe, Shannon, there's another slide there. Can we move to the next slide? Yeah. So these are the 3 topics today: Ontario's structured psychotherapy program, which will be presented by Lauren Flavel and Robin Bate, and then the Lakeridge Health mental health team and addictions, which will include Dr. Kevin Chopra, Dr. Jennifer Martins, and Beth Brennan, and Sarah Kipling, from the mental health team. And then Kipping, my apologies, I put an L in there. Sorry, Sarah. And then we'll have our usual breaks. What's the next slide? Sorry, Shannon.
The next slide is actually just for the break, Joel.
That's right.
So this is all we've got, and then yeah.
That's okay. I thought we had the structure of breaks. My apologies. So let me introduce our lovely guests today. So Dr. Lauren Flavel is a clinical and health psychologist in the role of regional clinical and training lead with the Ontario Structured Psychotherapy Program at Ontario Shores. She received her PhD in psychology from Toronto Metropolitan University in 2018 and her postdoctoral fellowship training at St. Joseph's Healthcare in Hamilton. She also serves as the director of training for the psychology residency program at Ontario Shores. And she is co-presenting today with Robin Bate, who is a clinical manager at Ontario Shores Centre for Mental Health Services, leading the Ontario Structured Psychotherapy and Healthcare Worker Assist outpatient programs. And with 16 years at Ontario Shores and 4 years with the Ontario Structured Psychotherapy Program, Robin brings extensive experience in clinical operations and project management. She's committed to delivering patient-centered, accessible care with a focus on improving client experience, reducing barriers to service, and driving meaningful program development and quality improvement. I will hand it over to their capable hands. And if you have questions, please put them in the chat or raise your hand at the end, and we will let you speak. Thanks, everyone.
Thank you. Shannon, are we pulling up our deck? Do you have it queued up? Would you like me to share screen? How would you like for us to go?
The plan was for you to share the screen, but I can queue it up and do that if that's easier for you. Okay.
No, I have it all ready to go. I just wasn't sure. I didn't want to disrupt the flow here. So let me just share quickly. And just to make sure everybody can see that okay. Awesome. Okay, so thank you for the introduction. So yeah, I'm Robin Bate, clinical manager at Ontario Shores, together with Lauren and Sarah. We're here today to talk a bit about the Ontario Structured Psychotherapy Program. So hopefully, you know, what we can connect on today. And I guess to start, we are, you know, if there's any questions or anything throughout the presentation, please feel free to raise your hand, throw it in the chat. We like to try to make this as collaborative and as engaging as possible. But we will also leave time for some questions at the end. So please feel free to jump in at any time. So throughout our presentation, we're looking to provide you some information on the OSP program pertaining to our referral process, our inclusion and exclusion criteria, our central intake and triage assessment. So really looking at pathway matching and navigation for individuals, our treatment models, and again, just opportunity for some questions and answers. So a little bit of background on OSP. In 2017, the Ministry of Health, they committed, or they announced their commitment to expanding mental health services in Ontario for people with anxiety and depression. And as a result, they launched a pilot. So this pilot was called the CBT Demonstration Project. And ourselves together with Waypoint, CAMH, and the Royal, we worked together to really develop this program, looking at our regional model, clinical protocols, training and consultation, and data, right? Like what the minimum data set and reporting requirements that we wanted to capture and look at as the program unfolded. The one thing that I do want to say about our OSP program is our training and consultation model. We have about 6 psychologists on the Ontario Shores team that really support a team of about 45 clinicians. And weekly, they have peer consult. They have opportunity to connect with consultants to really look at the clients that we're serving and ensuring that, there's opportunity to ask questions and connect with each other to ensure that we're providing, the best care possible. In 2020, the 3-year pilot came to an end, and the ministry announced the roadmap to wellness. And as a result of that, OSP became a permanent program. And we grew from 4, we call ourselves network lead organizations. So we grew from 4 to 10. And we grew to 10 to ensure that we could support Ontario in all regions within. So we wanted to ensure that our program is accessible, that our wait times were, as low as we could, have them. And that expansion just allowed for, again, more access for individuals to the service. And to date, we have, we continue to evolve year to year. And in 2021, we were very focused on individual, therapy sessions together with clients or patients. Now we also offer a number of different lower intensity options for individuals as well, which we'll talk about a little later in our presentation. This is a very busy slide. I appreciate that. But what it highlights is just our support model and the partnerships with certain service delivery sites or satellite delivery sites that we have across our catchment area. So, pardon me, the little map with that yellow shape is our catchment area. So we go across the lake pretty much from, we have York in Toronto. So that's kind of our Toronto angle down at the bottom left. And we go up through Newmarket past Seneca, which is kind of where we are on the 404. And then we go up to Bancroft. So through Peterborough, up Bancroft region, back down to Kingston, and then across the lake. So that's the region in which we support clients within our NLO. And all of these little orange circles are partnerships that we have with community agencies, with Indigenous community, with post-secondary, with hospitals, with primary care. And what our model is here in this regard is we have clinicians that actually work in community. So we have a clinician that works in the Fort Perry Family Health team as a part of that team. So they sit there together with that team. They will review, clients if there's somebody that, needs some supports, support through that referral process, get them connected to OSP. And we just find that it's a really good opportunity to sort of augment or supplement services within existing teams to be able to provide that additional care and supports for depression and anxiety. So we have about 45 individuals, 45 individuals across the region partnered in community. But we also accept self-referrals and referrals from others. This just allows for that in-person presence to be able to be seen in community by one of our clinicians. Just pausing. Any questions so far? Okay. So a little bit of an overview. Access to OSP can be either via self-referral or provider referral. Both of our referral forms are found on an Ocean platform, and they can be found either through accessing, we have a Make a Referral link on the Ontario Shores website, or through Access MHA, which you'll hear a lot about in a couple of presentations from now. But both are front doors to be able to receive and submit referrals for support within OSP. Primary care attachment is not required. So individuals through a self-referral process do not need that attachment, nor do they need OHIP to access our services. So some of our partnerships with the post-secondary institutions, we get a lot of international students, right? So they would have a UHIP number attached through the university in that regard, but they would still be eligible for our services. The one, caveat is that they have to be in Ontario. So for certain individuals that may go home over the summer or, over particular breaks, if they're not in Ontario, we ask that they pause or hold their treatment at that time until they return. As a part of our intake process, and we review all of our referrals, and we do an intake and a triage assessment. So we really, during this time, look at eligibility. Are we the right service? Are we the right door? We might not be the right door right now, but how do we get them connected to a support, to other services, as we review the referral information. Sorry, I saw something pop up in the chat.
Someone wondering if it's a separate referral form or the same Ontario Shores referral form.
So it is separate. So our outpatient services referral form is separate from our inpatient referral form on the Ocean platform. We just recently, actually, I think 2 days ago, OSP is its own referral form. And part of that reason is just certain priority pathways that are supported within OSP, internal just processing and with integration to our EHR, and also just support for our Indigenous pathway. So a few key questions on our referral forms that differ from other outpatient services just allowed for it to nicely be presented in its own site within Ocean. So it is separate. So within Ocean, you would search for Ontario Structured Psychotherapy. If you were to search for Ontario Shores and land on another referral form for outpatient services, it would redirect you on where to go to find OSP, but it is a separate form. I hope that answers your question, Dr. Lee. During our intake and triage assessment, we really look at the right match for the individual. So in OSP, we have a number of different pathways for them, different services, be it higher intensity or clinician engagement, or lower intensity options, which are more self-directed. And based on the area of focus that they're looking to receive services for, we really do, a pretty good, thorough assessment to look at that matching. We are a stepped care model. So if they do start in a particular service, there's opportunities for them to step up to a higher intensity service, which again, we'll touch base on in a little bit. And our services are CBT based, and they range within a step care framework from, self-administered strategies to weekly one-on-one sessions in either an individual or a group setting. And we, throughout our presentation, layer in just some information because we've recently introduced Etiwaktumuk pathway, or a two-eyed seeing pathway for Indigenous individuals. So this particular pathway was co-developed in a culturally safe and supported way with community. So just another service that is available for clients within OSP. And I'm going to hand it over to you, Lauren.
Thanks, Robin. We want to talk a little bit about cognitive behavioral therapy, but knowing most people on the call have a good, basic understanding of this, but just a refresher. Oh, before I do that, Dr. Lee wants to know what the wait time is. Robin.
So right now, it's going to depend on area of focus. So in a later slide, we kind of break all of those out for you. Our highest wait time right now is for trauma or CPT or PTSD supports. And it depends on whether it's virtual or in person. So I apologize, not a clear answer, but virtually it's about 2 to 3 months to see somebody for trauma virtually. In person, it's about 3 to 5, and that will depend on where they're wanting to be seen. So because we're scattered across the region, those individuals, it really is, when is their next available opening, right? And if they just started to see clients all now, some treatment sessions could be upwards to 20 weeks. So we just need to look at that turnover for them to be able to take on a new client. So that will make it vary a little bit, but typically on the high end, 5 months.
Great questions, keep them coming. So cognitive behavioral therapy, it's an empirically supported treatment for many conditions. Relevant for today is it's empirically supported to treat depression and anxiety related disorders, including post-traumatic stress disorder and obsessive compulsive disorder. It's important to know it's not the only treatment for these conditions, but it really has amassed the most evidence for many of these populations, and is endorsed by the NICE guidelines in the UK to be one of kind of the first line interventions for these conditions. So while it might not be the only treatment, it really is. If you have an anxiety disorder and you haven't done CBT, that usually is the go-to just to see if this will support them and help with symptom management. I also really appreciate that because it works for so many different conditions that it's created, we're very versatile. It means if your client comes in with many different co-occurring conditions, usually having an expertise in CBT helps you to treat most of those. So I feel we're quite an adaptable workforce, which is great. How it works, we in CBT really rely on a foundation of therapeutic rapport and collaboration. Therapists have some expertise and some skills in cognitive behavioral therapy, but the clients are really seen as the experts in their own experience. And we come together to kind of understand like what's under the hood, like what's getting a shared formulation of what's maintaining these specific symptoms using a cognitive behavioral therapy theoretical framework as a guide. We're kind of deciding together what goals to move towards. That's very much what does the client have interest in? Are they returning to work? Are they interested in being more social? So letting them kind of guide what success in therapy would look like. It really helps the therapist to know which techniques and treatments would be best to help the clients. The framework that we use is based on identifying both automatic thoughts and behaviors that might be maintaining emotional disorders. So just to give you some examples, in PTSD, for example, there are sometimes beliefs we call stuck points that keep people kind of stuck in the trauma. It might be thoughts like, if I hadn't been so polite, I wouldn't have been assaulted, or I can't trust anyone, or I can't handle my emotions. We're also targeting behaviors that maintain emotional disorders. For example, someone with generalized anxiety who worries a lot might be engaging in a lot of safety behaviors that maintain the anxiety, such as checking, maybe using ChatGPT to get reassurance. That's been a big one recently, or avoidance. And then in the session, the client is learning a lot of new skills. I mean, it still feels like therapy, but there's a lot of teaching going on. We're applying them in the session to real world situations, sometimes actually even going into real world situations in the session. If it's exposure based, we might go down to a food court or something like that. And then we ask them to do home practice, which is really a key part in the research of the outcomes that we get, is that people are practicing these skills regularly in their day-to-day life, coming back, letting us know how it went, how helpful was it. It also helps us to troubleshoot where they might be getting stuck. We track progress towards those goals that we set out at the beginning of treatment, in addition to questionnaires that check in on symptoms. We do offer CBT in individual and group formats, and focus on those measurable outcomes. So again, not just progress towards goals, but we collect data at every single session. So using the PHQ-9, the GAD-7, plus a functional measure just to see how they're functioning in their day-to-day life, as well as a problem-specific scale. And actually the UK found that adding the problem-specific scale actually improved outcomes just alone, something that's tailored to the symptoms that they're having, that's tracking progress. So for example, with PTSD, we use the PCL-5, and social anxiety, we'd use the SPIN. You can expect, again, it's not always a panacea, but we, see improved mood regulation, reduced anxiety and stress, enhanced coping strategies, and hopefully greater confidence in managing everyday challenges. Thanks. Next slide. So let's talk about who this program is going to be well suited for. And again, we say here inclusion and exclusion criteria, but we do get a decent amount of flexibility at the intake, just to kind of with judgment on where some of these fall. So we are really looking for who's going to benefit from cognitive behavioral therapy, who is in the place to benefit. Is there a treatment that's better suited for the symptoms that they're presenting with? Are they able to engage in the program right now, or is there too much crisis or risk or life circumstances that would make it difficult? We do see people 18 or over. There's no upper age cap at the moment, again, who present with anxiety and depression. And we'll go through the main areas of treatment a little later that might help you to also figure out who's a good fit, who's willing to attend weekly appointments. So if they have a big trip coming up, or again, to Robin's point, if they're out of the province, probably not the right time to join this program. We're looking for a couple months where they can attend the same weekly appointment and complete some practice between sessions. In terms of exclusion criteria, active suicidality. So we absolutely expect, passive suicidality that comes with the territory in terms of mood and anxiety. But when there is an active plan in place and some degree of intent to act on that plan, we really, don't function as a crisis service. I mean, certainly when people are in crisis, we can help them safety plan and get them to those resources, but it's not the appropriate referral when someone is kind of in an active suicidality place where that's kind of pressing for them. I know that can be hard to determine. We used to use basically a guideline of like 3 to 6 months. Like if they've been hospitalized for suicidality in the last 3 to 6 months, that's probably an indicator just to wait a little bit until that's more stabilized for them to come to CBT. Moderate to severe cognitive impairment. A lot of our materials are a grade 8 reading level. Bounce back, which we'll talk about more later, is at a grade 4 reading level. But what we really want to avoid is, frustration where they're not able to do the work. CBT does involve usually workbooks, worksheets, quite a bit of reading and writing, which again, limitation of the treatment, absolutely. And if they, acquired brain injury, learning disability, we just want to be mindful of the reading level and kind of what's required, although we adapt, again, as much as we can in terms of using visual aids and things like that. Acute psychosis and acute mania, again, it's not exclusionary to have a diagnosis of a psychotic disorder or a bipolar disorder. It's just that those symptoms are medically managed or are in a better place and are more stabilized, looking for about half a year of stabilization there. Again, don't want to give too much of a time. We take every case by case. It helps if they have a psychiatrist on board, for example, or are stable on medication. All of these things make us more confident that we can treat them appropriately, because we do not provide CBT for bipolar disorder, and we do not provide CBT for psychosis. So we would be treating co-occurring anxiety and mood conditions that might come along with that. We do work with the bipolar depression, like if their mania is treated, but they still have depression. But again, really looking to see that they've explored medication before coming to CBT would be ideal for bipolar disorder. A complex personality disorder. Again, we've kind of left it purposely vague. The biggest one that we see is borderline personality disorder. The evidence-based treatment for borderline is going to be dialectical behavior therapy. I know those wait times are long for those programs, and we're not a replacement for those programs. And so if someone comes with a diagnosis, we're really looking to see if they've gotten some skills in the community through DBT skills group or through a DBT program. And if not, that's usually our recommendation. However, if they've gone through some DBT and have some skills on board, we might be a really great option. Or if they're just, they have some traits, but they're able, they're not suicidal, they're not self-harming actively, we also might be a good option for them. An eating disorder, this is just, again, you can have some disordered eating on board, and usually an eating disorder has medical complications that we would want to be assessed and checked in on first. Also, if people are restricting a certain amount, usually that can lead to anxiety and depression concerns. So we don't want to treat it with CBT when really they just need to do more regular eating. Problematic substance use, again, it's kind of up for debate, depends on how functional they are, depends on how they're using the substances. Usually we're looking, if there's a certain level of substance use that we think has become a primary concern on its own, we might recommend substance use programming before they come to us. However, we do have a concurrent disorder program that we utilize quite a bit, where they can access an addiction counselor through Ontario Shores while they're with us for mood and anxiety or PTSD concerns. So again, we don't want this to be too much of a barrier for a referral. It's just if you think that they, we do take a look at whether they might need substance use treatment beforehand. High risk to self or others and at significant risk of self-neglect is pretty self-explanatory. Any questions here while we're on the slide? And also happy to take questions at the end if people have case examples. Okay, we'll move on, but again, lots of time at the end for questions. Robin was talking about our intake process. It just goes into it with a bit more detail. It's anywhere from 30 to 60 minutes done by a nurse or a social worker virtually. And the goal is, again, to make sure that they're suitable for the program, again, setting them up for success, that it feels like they meet the criteria and that they're a good fit. We also are looking for a main focus of treatment. People might be coming in with many different co-occurring disorders or concerns. We are kind of trying to get a focus, only because trying to do too much usually just dilutes the treatment. We're always happy to do sequential treatments. If there's multiple concerns, we adapt as best we can, but we also are open to them coming back for another round if, let's say, we work on the PTSD and then the depression remains. That would be fine. So we're looking for kind of what that main focus of treatment is, and then we're looking at the most appropriate service. And this is where Robin's point around stepped care comes in, whereby we do work to get most people into what we call lower intensity services. We really don't like that word because it makes it feel like it's lower efficacy. These are evidence-based treatments. They just have less therapist touch. So think about being mailed a workbook and having a coach. Think about ICBT options, and the data are really exciting in those programs, and we'll talk about them more, but we do usually start most people at that level with the caveat that they can step up to one-to-one group therapy at any time, no questions asked. So the model isn't that they have to fail that treatment, or isn't that they have to do the full treatment. It's that they just have to give it a try, and if they don't like it, they can be bumped up at any time. So we do send some people immediately to our one-to-one group options if we feel like their symptoms are severe enough, or that they maybe already tried some of the ICBT options. But a big part of this assessment is figuring out where to start people. Later on, Robin's also going to talk about our two-eyed seeing pathway for Indigenous communities, which is a really exciting pathway that we've been working on. And then if they're not a good fit for OSP, working on service navigation to get them hopefully to the right spot. So here's our stepped care piece. So again, we have kind of a menu of treatment options ranging from more self-administered strategies with support from a coach or a therapist. We're going to talk about each of those, all the way up to weekly one-to-one or group therapy. Services, again, have our blended Indigenous pathway, which is all individual therapy with problem-specific CBT. Also, our standard kind of normal OSP pathway, again, has our lower intensity services. We have 4 options to choose from low intensity. They don't try all 4. We send them to one of them that we think is the best fit. And then again, if they don't find success there, they come up to our manualized problem-specific CBT program, which can be done in an individual or a group format. And of course, the reason to do stepped care, as many of you would know, is just to make sure our one-to-one and group services aren't flooded and that the wait times are maintained. So again, I know sometimes it's not ideal to have a client go to low intensity, and it's what maintains our kind of flow and making sure we can offer timely access to service. Okay, on to the next one. Thanks. So our first low intensity service, again, low intensity does not mean low efficacy. Bounce Back has really impressive data. Bounce Back, many of you might have heard, because originally there was a lot of, you could refer into Bounce Back directly. Now it's part of OSP. They come in and get to pick from a number of different wonderful workbooks. The workbooks are only 3 to 4 pages, very simply worded. There's workbooks on anxiety, depression. There's a couple more down here. There's workbooks on sleep, assertiveness, alcohol and drugs. And they move through quite a few of those workbooks per week. So there's a lot of different topics that they can choose from. There is 6 phone sessions included with a coach. So a coach is different than a therapist in that they're not regulated to do psychotherapy. So they might have a bachelor's degree and yet still get a ton of training through OSP to do a good job here. It's just more so that they're encouraging the use of the workbooks. They're helping people troubleshoot what's getting in the way of doing them. And the phone sessions are spread over the 4 months. The amazing thing about Bounce Back is that they have evening and weekend options available for those phone calls. Also, really love that the workbooks are mailed to people and that they're so simply worded. I've taken a look at the workbooks and they're really accessible, and that we have a variety of languages for both the workbooks and the coaches. So there's a real place for Bounce Back in a lot of these ways. It's just kind of one of our most flexible options. And keeping in mind that a lot of these low intensity, I don't want to misspeak, Robin, but like people walk into them in about a week.
1 to 2 tops, yeah.
1 to 2 weeks. So it's really incredible in terms of having the intake and then almost immediately starting treatment, keeping in mind that if they step up, they probably would have been waiting for that high intensity treatment anyway. So why not do some of this work in the meantime? On to the next. ICBT, we have 2 vendors that provide our ICBT. One is Mind Beacon, again, a really sophisticated and impressive platform. They do problem-specific CBT. This is an app-based approach with asynchronous messaging. That means that people can message their therapist, they message back, but it might have a delay of up to 24 hours. We have heard great things that actually doesn't feel like you don't have a therapist. It actually might be pretty convenient. You can do a worksheet in the middle of the night and your therapist gets back to you the next day. So people actually really appreciate this piece, especially for like maybe younger folks who are really tech savvy. They're already on their phone. It's right there. And so again, they have specific treatments for PTSD and obsessive compulsive disorder, which is also really exciting. This is our one vendor for low intensity PTSD work. Tranquility is more of a transdiagnostic approach. So they have kind of a depression stream and an anxiety stream, which is nice because if people have multiple different types of anxiety, they can go into the anxiety stream and get support for many different types of anxiety. Again, both of these are customized. So the therapists on the other end, again, therapists, so they're master's level therapists, are picking the modules that they think are best, setting up different worksheets for clients to do. And there's 12 weeks of consecutive therapy for Tranquility. They also have longer access to the portal to support relapse prevention. And with Tranquility, there's also the option for a couple calls with their therapist. I think there's up to 4 calls. Those are our ICBT options. And bibliotherapy is our newest one. This is, again, self-administered. They have a dedicated master's level therapist. 8 weekly phone sessions. They're just shorter than our usual CBT sessions. They're 30 minutes instead of 50 minutes. This is only for depression, generalized anxiety, and social anxiety. But the manual is mailed to the client, and this manual would be the same manuals that we're using in our one-to-one and group. So they get a shiny, nice new copy of one of those and are working through the chapters with their therapist. So this is a well-used option, although again, only weekdays available and limited evenings. Our manualized, we shouldn't say problem specific. We do sometimes use a transdiagnostic approach when needed, but this is what we call our high intensity. Again, high intensity only meaning more therapist contact with the client. This is where they come if they step up for any reason. They're going to have a dedicated therapist with weekly appointments in both individual and group formats, both virtual and in person. We remain an individual program primarily. We're just seeing such an increase in PTSD and things like that we are trying to get more groups going just to kind of meet the demand. But really, mostly we still are doing one-to-one treatment here. Here's our main areas of focus, and notice that they're slightly different than the diagnostic term, and that's because we don't diagnose in this program, and you don't require a diagnosis in this program as well. So, and notice that stress and coping stress and worry is our new main problem descriptor. That one is because we were finding a lot of people were coming in without kind of an emotional disorder symptom presentation, but going through things like, a big transition with work or a transition in relationships or, things like the pandemic. There's a lot of, really stressful things going on in the world right now. So this allows us, it's a shorter program, but it allows us to treat it more like building resilience as opposed to working through certain kind of mood and anxiety symptoms. The number of treatment sessions depends on the main focus of treatment, but overall we can tell you it's about 12 to 20 sessions in total. Groups are going to be closer to like the 14 range, and individual just gives it a bit more flexibility to be either shorter or longer depending on the needs of the client. We also offer virtual booster groups in group format that are anxiety and depression focused. So when you finish a treatment, you're able to join us for a monthly group treatment. There's new topics, but also the biggest thing is a check-in, how you doing, and any agenda items that they have. So if they've finished OCD treatment, but they've encountered a bit of a lapse, they could join one of those groups to help with, do some new exposures or to get some support. Okay, on to the next. I'll pass it back to you, Robin.
Thanks. So appreciate all that, Lauren. So just a bit about our blended Attawaktamak pathway. So here, when we talked about treatment, typically, a session was about 50 minutes. When we're meeting with Indigenous individuals, we want to be flexible and able to potentially offer up to 90 minutes. So that way, if we want to start off session with a smudge or a drum or a song or a teaching of sorts, we have that opportunity to bring that in. Literacy options and support models, we're really looking at what can we do again to bring in the culturally relevant materials and make it more appropriate for individuals, be it in community or virtual. And below are some options or some examples of some of our blended materials. So when we look at the sacred circle, we're really looking at spirit. We're looking at other things as well and bringing that into the session and into the worksheet so that they're presented to individuals in a culturally relevant manner, something that really connects with them in that way. Again, looking at inclusion of cultural supports and our length of stay. So there may be a longer treatment series for this pathway. And part of that is really looking at trust and relationship, right? So we want to ensure that through those initial few sessions, right, we're really looking at, and we do that with all clients, but more so culturally as it pertains to individuals in our Indigenous pathway. Part of this pathway is from the time of referral, if they're in community, the Indigenous supporting clinicians would support a person with a referral. They would do the intake. They would support them through treatment. They would then connect with the circle of care in community and whatever health center they may be supporting, so that it's a singular pathway for the individual. In our standard pathway, the intake clinician, right, would do the appointment, the intake assessment, and then they would be seen by a different treating clinician. We've changed that in this particular blended pathway where it's the same individual from the initial point of contact through to the end, just to allow for that trust and relationship to really, start from that first contact. And then in discharge planning, we're looking at what we can do to work together with community to provide those ongoing supports post-discharge. So we're not just closing the door and saying we're done. We're saying, here's how we can get you connected with additional resources. Similar to what we do with service navigation upon discharge with other clients. But here it's really looking at how do we support that community connection, because that is, what we're finding is missing for a lot of individuals. And again, so discharge documentation really looks at that wraparound support. So as we have clinicians here in community, what are they doing together with other community supports to have that warm handoff for that particular individual to keep them connected to care? And the graphic here below is a catchment area resource guide that we've developed that really looks at all the Indigenous services and community organizations and communities, if you will, in our region. So together with community, we really looked at, layering in services that all of us were aware of. And we share this document amongst each other, just to allow for, again, awareness. What is available to individuals upon discharge? How might we be able to get them connected to other Indigenous organizations, friendship centers, others upon discharge and support? So document we can gladly share, always looking for more input. I know that at Lake Ridge in the Cancer Center, we have good colleagues there that are supporting some good Indigenous work as well. So they've also provided some input for us. So just a little bit about our blended pathway. So on this slide, it's just contact information for Lauren, Sarah, and I. Again, our webpage, links to our referral form. If there's any questions or, anything after the presentation that, you'd like to reach out to get more information on, please feel free. We're here. We would gladly provide that for you. And just two other things that I wanted to share with you. And one is our Healthcare Worker Assist program. So our Healthcare Worker Assist program primarily is supported on the OSP framework. However, the change behind, or the slight difference there is that it's rapid access. So we prioritize healthcare workers. So when we receive a referral for a healthcare worker, looking again for depression, anxiety, related supports, we probably get them in, within, I would say within a month to be able to start to receive services. And their treatment series is about 6 to 8 weeks. So we really look at what can we do to support them in a rapid fashion, because ultimately all of us need to be well to be able to support clients and patients and community. So we want to make sure that we are taking care of each other, right? So again, a free service, self-referral, no OHIP, no primary care attachment, very similar to our OSP criteria. That just wanted to share with all of you that it's available for us. And then lastly, we have a one-to-one psychiatry telephone consultation service that is underutilized at our hospital. And here it's just a quick plug that we have this available for MPs, physicians, family doctors to be able to book some time with one of our psychiatrists, to be able to connect and consult on clients, on questions, on, anything. As it pertains to a particular client and psychiatry services. So just this link here is there. You can go in, you can book a phone consult together with one of them instead of, submitting a referral, having somebody wait for a very long period of time to potentially get, some of the information that you might be able to receive ahead of time in a quick check-in or a phone call with one of our psychiatrists. So just wanted to share that with you as well. So it's in your information. And then, yeah, time for questions.
And maybe we could stop sharing the slides, Robin.
Sure, yeah.
Great.
Thanks, Lauren.
Shannon.
Kick us off. So thanks so much. Great presentations. So much information in a short time. So thank you for that. I think it's amazing to see all the programs that are offered and available. I certainly knew about Ontario structured psychotherapy, but I didn't realize the layers and levels of it and all of the options. So I think, Lauren, at the beginning, you had said, maybe it was Robin's slides in the very beginning, that you don't need to have OHIP.
Correct.
I just want to confirm, is that for like all of those options that you just shared? And do you need to have UHIP or some sort of coverage? You can be totally uncovered and access these services. I think that's really important because that's certainly a struggle that is encountered in primary care where you send people with no health insurance or none of that. So that's amazing. That's really great to hear.
And it goes back to, I think, the earlier question of like, are we on the same referral form? And part of that answer or reasoning behind why we're not is because it's not required. Where every other service it is. So we were causing problems, if you will, on a referral form and getting things across to the hospital because people weren't putting in an OHIP number. So yeah, for us, it's not required.
And it is just Ocean. There's the 3 options, as I heard, for referral on Ocean. 1 is your inpatient services, 2 is your outpatient services, and then 3 would be this Ontario structured psychotherapy. Is that where the Indigenous services are as well, or is there a 4th option? A 3rd?
No,
it's
they're
on the
within,
okay.
Yeah. So on our referral form, we do ask for self-identification, and if somebody does self-identify, the form changes slightly to support that particular pathway. So it is on the OSP referral form.
And sorry, I'm keeping them going because I've had so many questions. So if anybody else, feel free to throw something in the chat or put your hand up. But I know you mentioned too at the beginning about the catchment area where you have providers in different offices or things like that. Is there any opportunity for primary care to take some training, some education to become part of your network there, or to identify themselves as someone who likes mental health, wants to support in the mental health space? Is there any opportunity for people to grow and help you support that structure?
Absolutely. Right now, what that model looks like is we provide a clinician to support within the team. So ideally, what we do is if there is something identified or, within primary care, if there is, an office space that we can use a day a week or an afternoon a week or a morning, whatever that looks like, because we recognize space tends to be a challenge for most, we provide the clinician. Right? They just need an area where they can see individuals, right, in that setting and support the team. So they're there to be able to answer questions. If someone has a client, and they're not too sure what services, might be appropriate, again, that individual can provide some of that service navigation if OSP isn't the right service, right? What one might be, right? Is there another service at Ontario Shores or elsewhere? So it's really our clinicians coming in and being a part of the team. It isn't other, we could explore models where, that staff is providing services, but it would just be a different model than what we currently offer. Because right now we provide the staff.
That's probably an even better solution, to be honest with you. I think, everyone on this call can correct me if I'm wrong, because I shouldn't speak for primary care at all. But I think they would love to have, an expert to come into the office if they had the space and the ability to do so. And again, please, anybody ask questions or interrupt me. I hate to keep going, but I have lots more. We are working on a mapping project right now under the Department of Family Community Medicine to look at where are kind of those hotspots of people that are seeking mental health treatment and care. And is that something that we could work with your team on to say, okay, in this postal code or FSA, there is a high number of folks that are seeking those supports. Could we look at primary care offices in that area and try and attach some of your resources and supports to support that population that we know is going either to the emerge or, under OHIP billing, there's mental health codes that have been used. That's how the map's been developed. So it might be some good opportunity to look at that kind of neighborhood health model and how we can target some of the areas that need the help.
Yeah, definitely. We would love to explore that. Yeah, we love using data and all kinds of different ways to really help inform. Yeah, where we're where we're underserving, where we have, an abundance of individuals, it really allows for us to really scale up and look at how do we serve those areas as well. Yeah, we'd love to be involved.
Perfect. That's great. Thank you. I got all my questions answered. So I appreciate your time. I will pause and let anybody else ask questions, case questions. Feel free to bring up anything to the group. They'd be happy to walk you through. I'll just go ahead with one more then. If somebody got to the end of that, 6 weeks, 8 weeks, whatever their program, initial allotment was set to, what would happen if they did need, a little bit more time? Can they re-refer themselves or re-enter, or, are people just one and done? They have to wait a calendar year to come back or anything like that?
Yeah, so great question, Shannon. So we do allow for multiple rounds of treatment, although we are discerning, there's some people who just love to be in therapy. So we do take it a bit case by case, but really, for the most part, we just ask, we do have a bit of a hold period. It's not for any reason other than you've just come out of treatment, you've got some new skills. Why don't you spend 3 to 6 months practicing them and just solidifying them before we teach you a whole new round? But that being said, the clinician who's seeing them can waive that. If they think, hey, I need to have them back for a full other round, they can say, yeah, scratch that. So it just depends on the client, but they can come back. I do think on round 3 or 4, we're starting to wonder if CBT is just not working for them, and whether we need to look into another approach, IPT or DBT or something like that. But yeah, there are options. We do have some flexibility to extend the treatment if it's just a couple more will help them with a different problem, or just so that they don't have to come all the way back. And sometimes we do help them because we have a self-referral option, rather than bugging primary care, we can just help them with the self-referral coming through. At the same time, it's always nice to touch base with their physician or their NP just to say, hey, in our discharge summary that we send to you, it'll be, hey, they've finished. This is how it went. We do welcome them back in a couple months if they need it. That gives you the sense of you're welcome to re-refer if you want. So yeah, you're always welcome to re-refer back in if you think it would be helpful, knowing that it's not guaranteed. Again, if they go back to the high intensity, the low intensity, it might just be that they need a little bit more.
Yeah.
And we really also try to promote our booster sessions.
Yeah.
Right. So in between, right, re-referring, we encourage that they attend, a couple of booster sessions just to connect with a therapist, to connect, maybe that's all that they need. Right. So a couple of booster sessions prior to re-referring would be the ideal approach.
Amazing. That is great. And I think I heard you say, Lauren, too, so the family physicians should expect like a discharge summary to kind of summarize what has been the experience through the under structural psychotherapy. But between, do you give a notice that your patient's self-referred or anything like that? Like, what kind of communication goes back and forth to primary care?
Yeah, so in terms of finishing treatment, all of our services provide a discharge summary. Ours is, at high intensity might be a bit more thorough, just saying, how things went and their scaled scores from pre to post, and just any next steps. We have also implemented at the very top of this discharge summary, it'll say action or no action needed, just so you can quickly look and see, do I have to do something with this, that they finished or not. And then in terms of when we receive the referral, Robin, I believe we send a letter to say, hey, we've gotten the referral, they've been accepted to here.
So slightly different from a provider perspective. Yes, the outcome of intake will be sent back to the referring provider. So we've either, they're going the lower intensity route or they've been accepted for high intensity. That outcome is shared back to the provider. For the self-referring individuals, it's not automatically sent back through Ocean in that way. And that letter is sent through Ocean as an outcome of the referral process. The other documentation is sent through other means. I want to say faxing, electronic faxing, or whatever systems are in play. But on the self-referral, from the provider side, it's automatically sent. But on the self-referral side, I think, Lauren, they have to consent to sharing that back to their family, physician or provider. But they also have access to it in our patient portal. So if they wanted to download their information and bring it to their next appointment or whatever, they have that, access available to them to be able to share. But the self-referral isn't automated. It's only if they, consent to sharing that back. But the provider referral they would get that.
Yeah, it's a great point, the self-referral. And that might be, if they use a self-referral pathway, we always ask, is there someone you'd like us to be in touch with? And so hoping that they share those names. It's interesting. We went to a primary care kind of knowledge exchange a little while back, and some of you really like a lot of information, and some of you don't want to hear it, unless we need you. Yeah. So this is hopefully a nice balance of, a couple touch points just to let you know where they are and how they did when it's done.
Amazing. All right, last call for questions from the group before we let Lauren and Robin take a drink of water and stop talking, and we pass over to our next presenters. Great. Well, thank you both so much. Amazing presentation. I certainly learned a lot. So thank you for being here this morning. Really, really appreciate it. And I think this was really useful to hear from you. So thanks again.
Thanks for your time.